Hi, I'm Kim Keebler, the Editor-in-Chief of the Multiple Chronic Conditions Resource Center, and we are proud to have our speakers today. I'd like to introduce them as they discuss person-centered care planning for persons with multiple chronic conditions. Dr. Arlene Bierman is the Chief Strategy Officer at the Agency for Healthcare Research and Quality. I'm going to refer to that as AHRQ. Previously, Dr. Bierman was Director of the Center for Evidence and Practice Improvement at AHRQ. She is a general internist, geriatrician, and health services researcher whose work focuses on improving access, quality, and outcomes of health for older adults with chronic illness in primary care and in disadvantaged populations. She has published widely in these areas. She leads AHRQ in initiatives focused on improving care for older adults and people living with or at risk for multiple chronic conditions. She is currently leading AHRQ initiative to advance person-centered care planning. She is the senior author on the recent JAMA network publication on person-centered care planning for people living with or at risk for multiple chronic conditions. Dr. Brittany Watson is a clinical assistant professor in the Department of Family and Community Medicine at Wake Forest University School of Medicine and practices in family medicine at Atrium Health Wake Forest Baptist. She is the first author on the person-centered care planning for people living with or at risk for multiple chronic conditions. Dr. Watson's research focuses on chronic disease management, chronic kidney disease, primary care, and quality improvement. Her additional research interests include health disparities, health equity, and health policy. This podcast will be moderated by Dr. Jane Pederson. She is the Chief Medical Quality Officer at Stratus Health, Minnesota. Her role provides leadership and subject matter expertise for quality and safety initiatives across all care settings. Dr. Pederson has been actively involved in policymaking and advocacy in the field of aging, serving as a board member and co-chair of the Public Policy Committee at the State of Minnesota's Board on Aging. She is an editorial board member for the Multiple Chronic Conditions Resource Center and co-author of the recent publication, The Integration of Palliative Care in the Management of Multiple Chronic Conditions, which is an expert consensus paper with policy implications and was published by the American Academy of Nursing. I also want to make mention that we will leave a link in this podcast on the paper that will be discussed today, and we are pleased to have these speakers. And Dr. Pederson, I will turn it over to you.
Thanks, Dr. Keebler, and thank you, Dr. Bierman and Dr. Watson, for joining me today. Before we get started on just a series of questions related to the article and multiple chronic conditions, I'm going to ask Dr. Bierman and Dr. Watson to kind of set the table for us. First, I'm going to turn to Arlene just to give us some highlights around AHRQ's interest in this topic of multiple chronic conditions. What has been going on at the agency to date? Who do the multiple chronic conditions impact? Some of the key terms that we all should know before listening today, and then talk about some of the current federal initiatives related to MCCs. So Arlene, I'm going to ask you to start first.
So first I'm just going to give you a quick 20,000 foot overview of the Agency for Healthcare Research and Quality, because some of you may not be familiar with us, so many of you may be. The mission of the agency is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable, and to work with the rest of the Department of Health and Human Services and other partners to make sure that the evidence is understood and used. So why are we so interested in improving care for people with multiple chronic conditions? First of all, multiple chronic conditions is actually the most common chronic condition seen in medical practice and clinical practice. And 1 in 3 adults in the US have multiple chronic conditions, and 4 in 5 of Medicare beneficiaries are people over age 65. And, it has a huge impact on our health system. People with MCC account for 64% of all clinician visits, 70% of all hospitalizations, 83% of all prescriptions, 71% of healthcare spending overall, and 93% of Medicare spending. So clearly, this is an important group to improve their care. And on top of that, we have a legacy healthcare system that really focuses on disease-specific care versus person-centered approaches, which are needed, and whole person care when people have multiple conditions. So, what are we talking about when we're talking about person-centered care? Person-centered care is really the care that we all want, and we want for our loved ones, our families. Person-centered care means that individuals' values and preferences are elicited and, once expressed, guide all aspects of their health care, supporting their realistic and life goals. Person-centered care is achieved through a dynamic relationship among individuals, others who are important to them, and all of the relevant providers. And this collaboration informs decision-making to the extent that the individual desires. And that definition comes from a paper that was authored by the American Geriatric Society. And there's many, many definitions, but I think that one really sums it up the best of what the issues are. And so how do you deliver, person-centered care? Well, you need a person-centered care plan. And what does a shared care plan do? It gives a person direct access to their health data. It puts a person's goals in the center of decision-making. It's holistic. It includes clinical and non-clinical data, such as social data. And it follows a person through both acute and chronic care, and it allows team coordination. So AHRQ has done a number of things to be able to, you can see why we're focusing on multiple chronic conditions. Several years ago, we developed a research agenda based on evidence reviews, as well as extensive partner stakeholder consultation, and really identified the one thing, if we could improve care for multiple chronic conditions, would be to have a care plan, a person-centered care plan. And that's challenging to do. And then in order to pursue that, objective, we started by putting a request for information in the Federal Register to really hear from the field. What are people doing? So many people are innovating in this area and might not be publishing their work. What are the barriers and what are some of the solutions? And that's what you're going to hear about today. And before I turn it over to Brittany, I'm going to just say one more thing is when we're talking about multiple chronic conditions, we really want to address the continuum of risk. So the approach has to be one that includes prevention and chronic disease management and really takes a life course approach. So we really want to prevent, the development of multiple chronic conditions in people who are at risk. Those are people who have multiple risk factors. We all see them in clinic. And then there's a group of people who are rising risk. They probably have some diabetes, some arthritis, maybe some high blood pressure, but they're stable, but they're at rising risk. So it's a long-term ongoing management that is critical. And then a lot of the focus has been on the high-risk, high-needs patients. And clearly, those are the ones with complex needs who we really need to do comprehensive management for. Before one last point is that this is possible. There's a lot of energy in this area. There's a lot of work going on. And it really fits within a learning health system where we can, in an iterative way, learn how to do this well.
Thank you, Arlene. And Brittany, I'd like to hear from you as first author on the paper, Person-Centered Care Planning for People Living with or at Risk for Multiple Chronic Conditions.
Yeah, so thanks, Arlene, for really setting the stage for this conversation. And that request for information that Arlene referred to is what we analyze and what this paper is all about. And it was released in September of 2022. And there were 27 questions from AHRQ and other government agencies. So a lot of stakeholders were involved in crafting the RFI, and a lot of folks responded. So there were clinicians, individuals from academia, health educators, health systems, nonprofit advocacy organizations, industry organizations. We had payers. We had professional associations also respond, and there were a total of 58 unique responses, but there were a couple that crossed categories, so there were a total of like 69 that we counted. And this was really a team effort going through this analysis. So I really want to acknowledge everyone who contributed to the paper. And whenever we looked at all of these responses, it really shook out into different themes and subthemes. We came up to a total of 9 themes and 52 subthemes, and that sounds like a lot. But briefly, number 1 was suboptimal quality of care. Number 2 was person-centered goal-concordant care. Number 3 was multidisciplinary team-based care and care coordination. Number 4 was prevention across the life course. Arlene was just talking about that. Number 5 was digital health solutions. Number 6 was workflow. Number 7 was education and self-management support. Number 8 was payment. And number 9 was achieving community and health system payer goals. And some of the ones that really stood out to me was number 1, suboptimal quality of care. You know, we as clinicians and researchers and healthcare workers, we see it, and our patients are actually feeling it. It's not a secret. So it shows that we have to change in order to improve the experience and improve outcomes, like Arlene was mentioning. Also, the multidisciplinary team-based care and care coordination stood out because there's no single member of the team who can get this all done. The task is just too large, and we need folks from every discipline involved and engaged in order to make this happen. And number 4, prevention across the life course. As a family doctor, I was really excited to see this theme emerge because prevention is so important in preventing diseases in the first place and preventing progression and decline whenever a disease is present. And number 5, I think, was also important, digital health solutions. Technology is all around us. We have AI making a statement for good or for not so good, and we must embrace this technology and have it work for us. And Arlene and the team at AHRQ have been doing some very interesting work in this space, and I'm sure she's going to talk more about this one later on. And number 8, payment. That was really self-explanatory. We really have to figure out a way to make payment align with what we're really trying to achieve. In healthcare, if we want a better experience and better outcomes, we really have to invest in models that deliver that. And number 9 really encompassed that achieving community, health system, and payer goals. We all have an interest in seeing a positive impact of person-centered care planning and improving care for those with multiple chronic conditions. Everyone is involved: individuals, communities, health systems, payers. We all, want to see this improve. So those are some of the things that really stood out to me as we were going through these responses and crafting this paper.
Thank you, Brittany. I think you did a very nice summary. And what I really enjoyed about the paper is, we all know and acknowledge, there's some real barriers and some real challenges. And I think your paper did a very nice job of putting them into digestible kind of buckets. I'm sort of a bucketer, I guess. That we can talk about it and dive into. What I also liked about it is it's not only focusing on the challenges, but focusing on what can we do. So we know these are real. We know a lot of things aren't going to be able to happen overnight, but there are things that we can start doing. So that's what I'm hopefully going to guide us through in the rest of the podcast is, some of the things that we can walk away with today that each of us can be doing to make a difference in caring for people with multiple chronic conditions. So I'm going to start with my first question. Kind of a broad question, but what can we do now that can improve the experience of care for people with multiple chronic conditions and those caring for them? And I'm going to ask Arlene to respond from the perspective of AHRQ, and then Brittany from the perspective of what you learned through your paper, and then also as a clinician.
I shared the paper with my brother who is not in the healthcare field. And his response was, isn't that what, doctors and healthcare professionals are supposed to do? So I think people think that we do that. And most clinicians want to do that. But our healthcare system is structured where it's really hard to make it happen in terms of time and support to do it. So I think one of the things we need to do is educate our patients that we know how to do this. There's lots of models for making it work. And I don't think it's going to happen unless people demand it and realize. And I think the problem is you don't know until you're really sick and need it that it's not happening. So I think one of the first things to do is say, this is key. A lot of healthcare professionals want to deliver care this way. This is what patients really want to receive. They think they're going to get it and are surprised when they don't. So I think just raising awareness that there is so much we could do. I do think that there's going to be a tipping point. I'm actually cautiously optimistic because there is, Medicare, CMS is very interested in person-centered care, just released new payments for advanced primary care that can enable this. I want to really emphasize that primary care really needs to be supported and is key to making this happen. And as well as then the relationships between primary care and the rest of the system so that people get coordinated care. So and also, the advance of digital tools, we could talk a little bit that later, but I think there's so many reasons why I think we could make progress in this area.
I agree fully with Arlene. More support is needed in this space. People want to do this. Clinicians want to do this. We want to provide good care. We want to build these relationships, especially in primary care where a lot of this work is happening. So I do think that really providing support for the clinicians and just other folks on the care team as well. And a lot of that has to do with aligning payment and allowing for that to happen in the coordinated way that we're hoping for things to happen. And that's having, the right people on the right team in the right places at the right time. And then also really measuring that success, I think will be helpful in pushing this forward.
Thank you. And Brittany, your comments kind of lead me into my next question. So I'm going to ask you to respond first to this one as a clinician. We've all heard, and many of us know, that clinicians are experiencing burnout and just reduced joy in their work. So how do each of you envision care transformation for multiple chronic conditions making a change in the experience for physicians and the caregivers that are trying to provide that care?
I think really going back to what I was saying earlier, relying on the care team and having it not be on this one individual. Sometimes in primary care, especially in under-resourced settings, the clinician is expected to be the prescriber, be the therapist, be the social worker. And I think having these folks in place really distributes that energy and you get better care that way. You have folks who are really specialized in each of those areas, really helping our patients with whatever they're dealing with. That also leads me to thinking about like easing administrative burdens. That would help in that process as well. And as one of the things that came out in the paper and what you see in practice is really breaking down these silos so that folks have access to the information that they need at the time that they need it. So this is better coordination between inpatient and outpatient, between different specialists, between community-based organizations where patients may be receiving care that's related to their health. I think all of those things working together will help ease the burnout because right now the task sometimes just seems so large. Whenever you're breaking it down and you can trust that someone else is picking up in those other areas and all surrounding that patient, I think things would move a lot more smoothly and people would feel less of that burnout.
Thank you, Brittany. It is very true that it takes a team. And I think those of us that practice in geriatrics understand the importance of a team. And you're right, having someone else on your team that also is helping or can take some of that burden off makes a big difference. Arlene, could I hear your thoughts?
Yeah, I totally agree with Brittany. I think, the joy in practice, right? Restoring the joy in practice is those ongoing relationships and knowing your patients well and really partnering to optimize outcomes. and also relieving burden on clinicians as well as patients and their caregivers. Right now it's just so hard to navigate the system. It's hard to pull the information together. As people transition, especially people with multiple chronic conditions get often seen by multiple specialists, multiple sites and settings of care. They might have transitions. They might go to an emergency room, have a hospitalization. And how, I practiced for many, many years, and how much time and effort it takes to get all that information together. So if we could set up a system that really is centered on the person, on their goals, on having integrated, coordinated care, I think that will relieve a lot of burden and a lot of the causes of burnout for clinicians. And, Brittany mentioned this before, but one of the things, AHRQ has done, I've led the work in partnership with my colleague Jenna Norton at NIDDK, is we've developed interoperable shared electronic care plans. So these can actually aggregate data from multiple EHRs and also collect data that's meaningful for patients, their goals, their health-related social needs, and how they're functioning. To start developing a care plan. I think one of the challenges in caring for people with multiple chronic conditions is that we don't have a lot of good evidence. Most of the studies are done one disease at a time and exclude people with multimorbidity. So it's really the shared decision making. What do you care about? What are your priorities? And how can, our healthcare help you achieve your goals? And that requires conversations and partnership.
Thanks, Arlene. It's a good reminder. We are all a book with many chapters in, and reading only one chapter does not give us a full picture of what it means to really optimize our health and well-being. The next question, I think in many ways, gets kind of at the heart of what AHRQ does. So I'm going to ask Arlene to respond first. We often focus on barriers, but sometimes building on what works or where we have assets or success can be also important. So what practices do each of you see as working? What could be scaled that's already there? What would you like to see spread if you had your wish list?
I think I'll start with that one because, AHRQ is now leading a national initiative to learn what it will take to make person-centered care planning for those who need it and want it a part of routine practice and make it easy to do. And I think, one of the things is that there is actually so much innovation in this area, and there is so much, to tap on. We actually did an environmental scan where we found 40 different models of doing this. And I think, it's sort of the model of, evidence-based care and learning health systems that we really need to generate the evidence of what works, in terms of clinical care and interventions for patients. But at the same time, we need the evidence for how to make it work, what works best for, implementing this. And also every community and every practice is different, has different resources, different populations, different needs. So how do we actually identify what's critical and make sure that we could then adapt it and tailor it to like a local context? So, and I think, that's the learning health system model. I think we got to get started and we could keep learning. We collect data from practice and we learn what works and what doesn't work, and we keep making it better.
Brittany, I'd like to hear your thoughts.
Well, one thing I want to add to what Arlene mentioned about getting more information, getting more research in this area. And one of the things that stood out in the paper and that really speaks to me, I practice in a safety net setting, and the folks who were responding from those settings talked about how a lot of the research in this area, the little that there is often done in more resource or academic environments. So translating that down to like the community health center space may be a little bit challenging. So I think one of the things that we can do is get more information, do more research in those settings instead of trying to tailor it to those settings on the back end, like get the work done there in the first place. so that we can push this forward in those particular settings. But one of the other things that I think, just on the ground seeing, I think that there's promise in value-based payment arrangements, because one of the things that I see is CMMI's Making Care Primary model. It's really working to strengthen, some of the things that we're talking about: coordination between providers, addressing health-related social needs, creating alignment across payers. I think investing in evaluating models like that could be promising.
Thanks, Brittany. A very good point. Yes, there are highly resourced health systems, but a lot of care is delivered in rural areas, small clinics that don't have all of those assets available. But they do have assets. It's a matter of helping understand how do you use the assets you have creatively to be able to do the work, and how do we help them with that. So I really like your comments. The next question is one we've touched on a couple of times, related to digital. We all know digital solutions are always exciting. In this day and age, we think, oh, maybe there's an app, maybe there's something that we can build, and we don't want to totally rely on that. But in all honesty, digital it's a wonderful tool, and it will help us a lot. So I'm first going to ask Brittany, as a clinician, what are your thoughts on what do you see as particularly promising from the digital standpoint, and then give Arlene a chance to talk more about some of the work that's been going on at AHRQ.
Sure, I know Arlene has a lot to say about this, but one of the things that I'm seeing more in use on the ground is the use of AI, not to make medical decisions, but just to help with easing the administrative burden that clinicians face. I'm currently using one that listens to the visit and documents the note while I'm having a conversation with the patient. And I like it because, again, it's not making medical decisions, I'm doing that, but it's freeing up my hands so that I can engage more with patients during the visit. I know that it's capturing what's happening in the visit, and then I don't have to spend my time documenting, and I can spend more time really understanding the needs of the patient that I'm dealing with, understanding their goals and their priorities. It just frees up my time. Instead of typing and occasionally glancing, looking at the computer, I'm really having that face-to-face connection, and I think that's so valuable in making these things work.
I think we have to be careful with digital tools because they could create harms as well as good. And part of the burnout is that many of our current EHRs were not designed around this person-centered care and create a burden for clinicians. So what Brittany was talking about is like tools to overcome the burden of the EHRs. And I think, that brings up an important point. I mentioned before our e-care plan, and the way we designed it was we designed it using user-centered design with, clinicians, with patients, with caregivers. What would be useful for you? How can we develop this in a way that's useful for you? So I think that digital tools really need to engage the users up front to make sure that they're, really helpful and not burdensome. And I think the other thing is we have to be careful about, the other thing that AHRQ has done a lot of work on is, kind of bias in algorithms. And we have to make sure that as we do AI, that we're assessing, we're making sure that it's equitable and fair and giving, the right answers to the right people. But that being said, and also the need in terms of generating the evidence about what works really has to be co-production and co-design in partnership with clinicians, frontline clinicians, the whole clinical team, as well as patients, caregivers, and communities. Because I think the only way we're going to get solutions that are really meaningful and sustainable is to engage, widely in developing this evidence.
Thank you. The digital is such an interesting area, and I think we're going to see so many exciting things come out, especially with AI, as we learn how to use it. You learn what to use it for and learn what not to use it for. Before we move to our last question, I just want to bring us back. I think you've both done such a good job of highlighting and getting a little bit deeper into some of the issues that the paper kind of gets into, and really talking about how we can help not only clinicians but also patients and families start to see that there is a different model out there for care, that the current way care is delivered is not the only way. And once we start doing that and people start realizing that we can look at them as whole people and look across all the things that impact their day-to-day lives, we're going to see more demand for that. And that's going to bring both what clinicians want to do and what patients are looking for close together. So I think this is just such an exciting conversation. So as we wrap up, what I'd like to end with is, transforming care is really a multifactorial approach. So what can each of us do to help move forward and build momentum? What can we start doing tomorrow? And I will actually go to Arlene first and then Brittany.
That's a $64 million question, Jane. And I don't think there's an easy answer to that. There's no magic bullet. But the reality is there's a lot we could do. I'm very excited about AHRQ's work in advancing person-centered care planning that's being done, led by OHSU right now. And we're really learning. We have to tap on, the innovations, the expertise of all the different sectors involved and bring them together. And one of the things AHRQ is going to do is really put together some recommendations for what individual people can do. But I think realizing when we started, people think this is pie in the sky. We're so far off from it in our health system. But as we engage, people get excited. And there are examples of people making this work who can share it. So we need to learn from each other. We need to realize that this is a possibility. And, I think it's going to take collaboration. It's going to take working together, different disciplines, different sectors, with the community, with patient organizations. And I think we need to all put our heads together and decide everybody wants this and it's so hard to make it happen. What do we do to move it forward? But on the other hand, we have, there's so much going on that can make this happen. As Brittany said, the value-based purchasing could enable this, some of the new payment codes, digital solutions, and growing evidence about that actually delivering person-centered care is feasible, and it does, help us achieve the quintuple aim.
I 100% agree to all of that. And generally speaking, continuing to talk about this work, like we're having conversations like this and advocating for change. Like Arlene has mentioned, we need more research regarding best practices. And that was also a reoccurring theme in the responses to the RFI, and I see that on the ground as well. And as an educator, I would be totally remiss if I did not mention the importance of embedding this into training, undergraduate and graduate medical training, training our advanced practice providers, nurses, case managers, pharmacists, everyone who's on the care team. And for busy clinicians, lastly, who are interested in moving this forward but not really sure like where to go, or you feel like you don't have the resources, I would just simply start by asking patients like what they value and what they desire, and you'd be surprised like what that simple question can do and how that can change the trajectory of your relationship with your patients and how you provide care. So those are the things that I could think about.
Thank you. I think it's just important sometimes just ask and you'll get an answer. So thank you to both of you. This has been a great conversation. Hopefully everyone that's listening will have a chance to read the paper. There's a lot of really good information in there. Kim, I'm going to turn it back to you to close us out.
I want to thank you for all that you brought to this podcast. I also want to make mention that all four of us are part of the learning community for person-centered care planning for patients with multiple chronic conditions through AHRQ. Dr. Bierman, you are a leader in this area. We're so grateful for all the work that you do and the agency does. And Dr. Watson, thank you for the paper. Dr. Pederson, you do your share of work for this patient population, and we're grateful for all of you. Is there anything that you think is important to say to our audience before we conclude?
No, I was just going to say, I think just remember we can do better.
All right. Well, thank you, you guys. We finally did it. It took a year, but we did it.